Welcome to Startup Health Now, the weekly web show that celebrates the healthcare transformers and change makers reimagining healthcare. My name is Unity Stoakes, and today we're at the Wearables Tech and Digital Health Conference here in New York City, which is organized by ApplySci. Very excited about our special guest today, Dr. Douglas Wood, who is the medical director at Mayo Clinic of the Mayo Clinic Innovation Center. We're going to be talking about innovation pathways for entrepreneurs, the role of technology with physicians and health practitioners today, and predictions for the future. Stick around, it's going to be a great show.
It is the duty of leaders to lead, of the creative to create, of the daring to do. The free world expects leadership of us. Its fate and our fate depends upon our leadership. We are industrious, inventive, restless, with the fires that burn within us. But I say that nothing is easy, and the best things are the hardest. And all our troubles, all our immense difficulties, now and in the future, can I say, be solved if we have the will, the courage. The future is to those who take it.
Welcome, Dr. Douglas Wood. Welcome to Startup Health Now. It's great to meet you, and thank you for taking the time to be with us today. Just wanted to start with learning about you and your background. Why healthcare? When did you first decide to get into healthcare? And by way of background, I should say you're the medical director at Mayo Clinic Center for Innovation, and you're also a cardiologist.
That's right. So I appreciate the chance to spend some time with you today, Unity. It's a great experience to come to New York and talk lots about what the future could be with lots of smart people. My career in healthcare started a long time ago, actually, way back in 1973 as I was graduating from college. I wasn't actually sure what I was going to do and had an interview with the medical school in my hometown, as well as an interview with the State Department scheduled for several weeks after that. As luck would have it, the medical school sent me a letter that was in my mailbox when I got back from Christmas break that said, we'd love to have you come, send us $100. And so the price was right, I guess. So
back when it was $100.
Yeah, so I sent him $100 and ultimately did the State Department interview and decided I would go ahead and do medical school. So that's actually how it started.
And you're still practicing today, correct?
I do. I spend actually about half my time practicing cardiology. The kind of thing that I do is really complex diagnostic work. So most of the people that I see are ones who have symptoms for which a diagnosis has not yet been established, or they may have really complex problems and it's been difficult for their physicians to decide exactly what to do. So that's the kind of thing that I deal with almost every day. It's just tough decisions in terms of diagnosis or treatment.
So in your role focusing on innovation at Mayo Clinic, how important is it that you're still spending time with patients, still practicing, about half your time?
From my perspective, it's really critically important because I can bring to our work a better understanding of what people are encountering and seeing where they're having difficulties. The kind of work that we do in the Center for Innovation depends a lot on observational research. So our design staff, we have about 14 designers, really practice a kind of innovation where they spend time observing people in their interactions with the healthcare delivery system or in their homes or where they go to school. And to try to understand how those people are making decisions about their health. So behaviors are a big thing. I have to say that my work in the Center for Innovation has given me a much different insight into my work as a physician. And the ability then to bring that clinician's insight back to the laboratory when we're doing experiments adds another dimension. It's really, I think, not good just for me, but for our designers, because we can engage in discussions about the meanings of some of the observations that they've been making. And sometimes we can actually test a little faster specific concepts than we might have otherwise been able to do. So I think it's very important that I am a practicing physician as part of an innovation effort aimed at health and healthcare.
So what are you trying to achieve at the Center for Innovation? Are you building things internally? Are you looking also for external innovation? How does that work?
So our mission, as we describe it at the Mayo Center for Innovation, is to transform how people experience health and healthcare. And it's important to recognize that health is the first word. We are not about looking solely at the process of health care. Now, we have learned from our research that people have a very different perception of health than typically we do as physicians. Much of the time nowadays, physicians are measured on things like clinical performance. For example, how well do you control blood pressure for people with high blood pressure or blood sugar for diabetic people? The measurement systems actually don't ever say anything about, well, how did you actually help this person live better? A really good example of that is if you look at people who have bypass surgery for their heart disease, for their blocked arteries, depending on which article you read, for people who were working before their surgery, between 30 and 70% of them never go back to work. So the operation might have been a great success by virtue of the usual clinical measures of, well, the patient didn't die,
right,
and there were no other complications.
But in terms of their life.
But in terms of their life, it may have been a dismal failure.
Right.
And another way to illustrate it is that frequently now I will ask people who are confronting that decision, what are you worried about the most? I never used to really worry about that too much. I used to just tell them, here's your risk of dying and here's your risk of complication, because I figured that's probably what they were most worried about. But about a month ago, I was talking with a person who worked for a moving company, and I asked that question, and really the worry was not about dying or having a complication. The problem was he was worried about being able to make his mortgage payments and what would happen if he didn't.
Right, yeah. Yeah, just living life in the everyday
Absolutely.
Struggles.
Right.
So in terms of bringing this down to a practical level, what are you trying to achieve? Are you trying to commercialize new solutions that people use, consumers, patients, or also physicians? What's the end goal, I guess?
Our work is defined mostly by Mayo Clinic's strategic plan. And so fundamentally, Mayo has a goal to be a trusted and affordable partner for the people that it serves. And a corollary of that has been to say that by the year 2020, Mayo Clinic would touch 200 million people in a meaningful way. And if you think about where we are today with people coming to us, mostly when they are sick and need something, there are some who come to us when they're well. We've bailed them out of a particular problem and now we're taking care of them on a long-term basis. Or there are people who are coming for regular examinations or checkups. But that number of people might be 2 million. So just the bold statement of our leaders to say that we want to touch 200 million people a year by the year 2020 says you have to think about doing things fundamentally very differently. So as we look at our research, we've learned that people really want to have help when they have to make a decision about their health in a way that makes them feel comfortable and not abandoned. We have a tagline that we say, always be there for me. So it doesn't make any difference whether I'm at home or at work or at school or maybe at a soccer tournament or on vacation. Maybe I'm in my personal physician's office, or maybe I'm in an urgent care center and I just need to know more so I can make a better decision. How can we actually do that? That's a really important part of health for most people is making that decision. So we tend to focus a lot on that. Now, we also do a lot of work internally with the healthcare processes at Mayo. And there are reasons for us to do that, including making people have a different experience at Mayo than they might have at any other healthcare provider. So for us, the experience is the most important thing that we work on.
And a big part of our audience are healthcare transformers, entrepreneurs,
Yes.
innovators, people building things. You mentioned designers. You get to work with a lot of designers. What opportunities are for them to engage in this mission that you have, and what advice would you share with them on maybe the best approach to connecting into what you're really trying to do? Are you working with external innovation yet, or is it really not designed for that?
We actually do work with external groups. Mayo has a relationship with Rock Health and with Techstars in particular. We, at our annual conference, Transform, this year are inviting a number of startup companies to come and present. And we're sponsoring a competition this year where we hope companies will join the competition to see who can come up with the best ideas that might be worthy of a prize that will be $50,000 to help them with their work. So those are some of the ways that we work with outside groups and entrepreneurs, or some people would say disruptors. Other times, some of our clinicians might make contact with a startup company or an entrepreneur and have a specific application that they want to look at. And we may be part of that. Sometimes it's a matter of using it as part of our experimentation. Sometimes actually a physician may not know exactly how the thing is going to work. And it's not clear whether the entire idea could actually be scalable and attract additional funding. So we have a function within the Center for Innovation that we call the Garage. And so this is intended to help those Mayo physicians and scientists who have an idea or might be working with a small startup looking at a specific solution to bring it in and say, this is what we're thinking. Then we will help them look at it in a critical way to see if there's potential for it. And if there's a way, then we can transfer it for further development. We'll try to do that.
So do you have any advice or maybe some lessons learned to share with these early stage innovators on what they should or could be doing differently? For example, what should they be building? What types of solutions are needed?
Well, I would hardly want to be prescriptive in the sense that it is kind of antithetical to innovation to say you should only do these things or you should only work on those things. Really, what we're most interested in, again, is thinking about how new things can help people live their lives. So there may be lots of applications for specific innovations that people have that would be great applications, but they wouldn't necessarily be ones that we would be interested in working with because they don't fit into a framework that would allow us to use it in a way to improve the way that people live. And that doesn't mean that was a bad idea. It just means that for where we've decided to focus, that's really kind of what we want to do. So there are so many people and entrepreneurs and companies that are working, and we have a reasonably large operation. I mean, we have about 65 to 70 people.
All in one location or spread out?
Most of them are in Rochester, but we have an operation in Arizona. And the Arizona operation is actually working a lot with Arizona State University, looking at health in a college student population. We are soon to start an operation at Mayo Clinic in Florida. And we will be opening the Well Living Laboratory in Rochester later this year, a collaboration with Delos Living here in New York. That will give us the opportunity to work with companies and potentially startups looking at the way that the built environment influences people as they live and work. So that one we're hoping to have up and running by the beginning of next year, ready to do experiments by 2016. We have an advisory council and a scientific advisory group that will determine the research agenda. I suspect that at the beginning they're going to be very interested in things that influence activity and sleep and the balance of life in that way. But there are lots of possibilities. For example, in the presentations today, we're hearing about sensing technologies that people can wear every day. Maybe if they didn't wear them all day long, we might in fact learn more about the physiology of those people by watching them just at nighttime or at home, particularly if they do certain things at home, like do their workouts at home. So there are lots of possibilities. As I say, we're not trying to be prescriptive in that regard. We're really trying to think about defining some areas of research interest, doing some initial experiments, and then going from there to look at different research opportunities.
And where do you think we are in just the life cycle of innovation, if you will, as you think, especially over the last few decades, of where health and healthcare have really come from? Are we much farther along? Are we just at the beginning of what's possible? What's your view on where we are?
I think we're just at the beginning of what's possible. Much of the electronic innovations, for example, that have been applied in healthcare have been towards simply creating an automatic version or an electronic version of an old paper record. For this purpose, nobody has really thought about how would you fundamentally change how you deliver health care. We've all been focused on how do you structure a record that was used in the era of paper and typewriters. Mm-hmm. And for the most part, all we've really done is we've converted that into an electronic representation of a piece of paper on a screen.
Right.
And we're using documentation rules that were actually developed by Medicare back in the 1990s that drive all documentation. And nowadays, the irony is that Medicare is worried that the rules it created have been subverted by the electronic record to make it seem to Medicare that people are doing a lot of work that never occurred. So ironically, now Medicare is concerned about fraud and
right.
abuse facilitated by the very systems the government wanted to pay a lot of money to physicians and hospitals to implement. Well, to me, the remarkable piece is if you think about, say, wearable computing, as a physician, if I'm using a wearable computing system, I potentially could create a video record of the entire visit. And so that...
And store it in the cloud.
I just store it.
Yeah.
And so if anybody ever wanted to know what was in the visit, they could go look at it. So if somebody was concerned that I actually never saw the patient or I didn't do what I said I did, the video record is there.
Do you think physicians would embrace this or not?
Well, I'm not sure yet. We're going to do some experiments, some expanded experiments with it. It's kind of interesting, too, that if you look at it again from a user perspective, we have a great opportunity to let people see their visit and use it in a different way. I was observing an encounter of an older woman and a physician a couple of months ago. The traditional physician in the United States is working on about a 15-minute schedule, maybe 30 minutes. And in this particular encounter, a woman had been in the hospital for her lung disease and had been at home doing rehab and having trouble. There were lots of things that were actually talked about in that short visit, including prescriptions for 4 medicines and some things to do at home. This woman's daughter actually was sitting next to her, and you could kind of see the daughter trying to furiously think about, can I make written notes? Do I put things in my iPhone? What do I need to remember for home?
And if it was recorded, they could review it later.
And I'm sure they got home and mother and daughter said to each other, now, what did the doctor say about this? And their notes, I don't know what their notes were like, but I looked at the written note from the visit. Even the written note made by the physician came nowhere close to describing the richness of the interaction. But for the patient, if there was a question about what actually happened, if we just gave her access to that record and said, here's the video snippet of your record, just like YouTube, that's you, access it, you can play it back and forth as much as you want, even with your daughter next to you. And then there's no question about what was actually covered. And if there is a subsequent question, then we can actually get you to talk with the care team without having to go back into the office.
And that could help even with liability or compliance issues. It's better for the patient if they want
compliance.
Yep.
If we could get Medicare to think of using a video record as opposed to saying you have to have the documentation done in a specific format on a piece of paper, that if you printed it for us to look at or if you made a PDF for us to look at, that we would recognize that we could see all of the required elements for billing.
So what are the biggest changes you're seeing, maybe compare from when you were in medical school to what you're seeing doctors that are just coming out of medical school today? What's changed? And are we changing fast enough?
Actually, I might be a little cynical here and say I don't think a lot is changing. The thing that is changing is that there's a focus on how many hours a week a physician works. Another thing that's changing is that there's so much more information to know about nowadays. And probably the most significant tool that you might use nowadays is not really a stethoscope, but really your iPhone to help you access large
information.
Exactly.
And you see things like Watson.
So Watson actually has a tremendous capacity as well. So there is just so much information that's difficult to keep track of. So when I graduated from medical school and started my residency, there was one leading textbook of cardiology and a close second. There was actually one journal about cardiology, and it was published on a monthly basis.
And you had to pay a lot for it, probably? Or it was hard to get access to?
Relatively a lot, and it would come, and of course you could read it. You could read it over about a month before the next issue would come.
Right.
So there was usually plenty of time to read it. But now I have roughly 8 journals, if I could read for cardiology alone, that I would read. I don't have the time to do it because they're published now rather than once a month. They're published every 2 weeks. And then there are online supplements with it. So it's just impossible to keep up anymore in the traditional sense. So you have to be able to use modern tools of processing lots of information to help you make decisions. It's also fundamentally more difficult for people to decide because there may be more complexity for them to try to understand, and physicians in general don't do a very good job of helping people to understand those options so that they can make a reasonable choice. So the technologies that we have coming, I think, offer the promise of really fundamentally changing medical decision-making and medical care from more of an authoritarian physician dictated or directed, I don't think dictated is necessarily too strong a word, kind of care into a participatory kind of care where we help people make better choices about their health by fundamentally understanding people as they are, not just as their disease. So I hope that is actually part of innovation in medical curriculum, medical school curriculum in the future, and that is that we really think about a totally different interaction and a totally different role for physicians than has been the case in the past. One based on diagnostic assessment, decision making, this is what you likely should do, and if you don't, then somehow you're not compliant as a patient or not adherent to what we tell you to do. There are lots of interesting stories that I've seen over the years to explain some of that, but I'm hopeful that that is going to be the way the future will be. And I think it'll be then finally great for people. We could potentially talk more about that, but I think that's where the opportunity is, and as I say, I think we're just at the beginning of that.
So if we're just at the beginning, what are your predictions, if you could sort of look into the crystal ball, and where is innovation taking us, both from maybe the perspective of the clinician and healthcare, but also in terms of people and just our life and our health?
So I look at the future as being one where, as a physician, rather than being responsible for kind of one patient at a time, my care team and I are responsible for a large number of people. We will understand fundamentally what every one of those people wants to do. We will, together with those people, develop a set of goals that we would call a care plan, but it's co-created. We would have the chance to look at it all the time and change it as necessary to let people live better lives. For example, now, if you think about somebody with diabetes, we pay physicians on the basis of how low the hemoglobin A1C might be and how low the blood pressure is.
Right.
But our experience, our research tells us that people with diabetes don't want to think of themselves in those terms. They want to think of themselves as living with diabetes, but not being diabetic and trying to live with a blood sugar measurement as we've defined it. So their goal might be, because the burden of the treatment is too great, their goal might be, I don't really worry so much about whether my hemoglobin A1C is 7. I really want to be able to not have low blood sugar reactions, for example. Or I want to be able to go to my daughter's wedding in a month or whatever. Or if things change, for example, if suddenly there is a new cancer, then there may be some things about that cancer that would say, for right now, we don't really want to pay any attention to a blood sugar level. Now, again, the physician's going to be paid for the blood sugar, not for improving the role of function with cancer. So it's a challenge for physicians because they have to make decisions that might have an impact on their payment.
Right.
But if our payment was structured on, well, what we really want you to do is to keep this person able to do all the things they want to do.
More of the outcomes, the holistic outcomes.
Exactly. The role functioning, then that really has the potential to change how healthcare is practiced and delivered. And I think that's the great promise of the future.
Do you see this happening globally? I mean, just listening, it sounds like this is how it might happen in the U.S., but what about in severely underserved communities where they don't have access to even a doctor? There may be one physician for tens of thousands of people. Again, looking at the predictions, will these populations get access to care in the future?
They will. I think it is scalable. So some of the work that we've done in primary care tells us that there's a way that's going to happen. So in the traditional way of delivering care in the U.S., it's always been a physician-patient model, maybe with a nurse working alongside to some degree. And a physician and a nurse together might take care of perhaps 2,000 people that way. But we actually, with our designers, looked at why people went to the clinic, and we asked them, well, why are you here today? What do you need to accomplish from your perspective? And who should you see? Who would you really think is important to see a day? And most of the time, a physician was not necessary.
Right.
Actually, only about 6 to 12% of the time was a physician actually necessary. Most of the rest of the time, you could do something without a physician, and about 12 to 15% of the time, if you really thought about it, you didn't need a licensed person, and the patient actually didn't even need to be in the clinic. We could have done things very differently. And then when we looked at that and said, well, if we used a care team that was based on what patients really needed, we would use a physician, a care coordinator who would probably be an advanced practice nurse, maybe one licensed person like an RN or a physician's assistant or a licensed practical nurse, and we would have 3 or 4 non-licensed people that we actually called wellness navigators.
And maybe they focus on nutrition, decision-making, advocacy.
All of that, plus things like making sure you could get your food stamps, you could get heating assistance in the winter if you needed it. In the experiments that we did, we actually had a circumstance where one of the wellness navigators helped somebody get a job, just go through the process of getting a job.
So it sounds like there's an understanding that it's really the holistic factors in someone's life that impacts their health and wellness. And
we know that is true because the determinants of health are largely not related to clinical interventions. But having an optimized care team like this, as we looked at what a care team could do, we figured, a care team like that could take care of 8,000 people instead of 2,000 people.
It's amazing.
Maybe even more. So right away, you can see that all of the worry about projected physician shortages in the U.S., much less the world, could go away.
Yeah.
And especially with the new technologies, this is the great thing about the innovation that's coming. The technologies are finally here to give us a way that we could even magnify the touch of teams like that.
Yeah. Couldn't agree more. So I thought we'd finish just with a speed round of some questions. Just a couple of questions here. So starting with health tips. How do you stay healthy? Any health tips that you recommend to your family, friends?
So
maybe the first one or two.
It's all about the basics. Don't smoke, be active, eat well, and live well.
Sleep?
Sleep is part of living well.
Oh, I like it. Okay. A book that you recommend to any health innovator, any books that come to mind or something that people should be reading?
I've been reading less books lately and spending more time listening to people really just talk about wild ideas. But fundamentally...
And you do that on podcasts or online or conferences?
Podcasts, blogs and all kinds of other things. So I have to say I'm reading fewer books and trying to just get as many ideas as I can by looking at as many different sources these days. So a traditionally produced book hasn't been part of my reading habit for a while.
Wow, okay. Favorite wearable?
Right now, my watch.
All right. Is it an Apple Watch?
No.
Or okay, old school.
Right, old school because, right now, the way we're looking at wearables actually isn't where we're ultimately going to be. So a future wearable isn't going to be defined by a piece of jewelry or something like that you attach.
Do you think it's going to be embedded into us?
Oh, it very well could be. So we're actually looking at the future of sensing in terms of sensing that is done through very flexible small patches that you wear or injectable small technologies. So already there are injectable small technologies for monitoring heart rates, and it's not hard to imagine that we can add to those fairly quickly.
So everyone would have, the same way someone has a pacemaker, the old way, everyone has something monitoring their heart at all times persistently.
Well, especially if you're going to need something like a pacemaker, you're going to have much more monitoring capability than you ever had before. And I think that as we look at the troubles we have right now with some of the side effects of treatments, say the side effects of treating blood sugar or blood pressure, having wearable or implantable monitoring data will be much more useful to people in the long term to make choices about what works best for them. sort of their sweet spot. So if I think about, right now, if I sit down with you and say, your blood pressure is too high, we're going to give you this medicine. I want you to keep your blood pressure between 120 and 140. I'm only doing that because I know that if it's above 160, your stroke risk is too high. If it's below 100, your risk of blacking out from low blood pressure is too high. I want to be somewhere kind of in between. But I really don't know if you're going to actually function very well at that level.
And it needs to be personalized.
Exactly.
Yeah.
Right.
So here's a tough question. So is there something that you believe that most people don't?
Well, one thing I've learned about people and their health is that people have reasons for doing what they do. Most of the time, they don't match my reasons as a healthcare professional, so I have to change my focus and stop believing that I have the only reasonable focus on healthcare decisions and that I have to make people adapt to me. Rather, I need to adapt to what people need.
Yeah. It's great. So last question. Any favorite quotes or words of wisdom to leave people with?
That is a hard question. In our work in the Center for Innovation, we get asked a lot about design by people thinking about design as making something look really great. But Steve Jobs probably said it best: "Is design is not about how something looks; it's about how something works."
Beautiful. Yeah, I love it. Well, thank you so much. It's really been a pleasure speaking with you today. Very valuable conversation. Thank you.
I enjoyed the conversation as well, Unity. Thank you.
Thanks. Thank you all, and see you next week.